meeting, and it's a pleasure for me to attend this meeting. I've been in person to the convention in Jaipur and in Chennai early in the last decade, and so I'm happy to be back. My talk will be about my experience about the treatment of these cartilage lesions, and what we will deal with is always this 4-degree full thickness cartilage lesion down to the bone. And you know the algorithm, and I don't want to bore you with this, but you see that I put now the Autocot or the minced cartilage wherever you formerly have been proceeding with Amic or Macy procedure. So for mid-size or even large sizes of defect, up to 1 to 4 centimeters or even bigger than this. For small lesions, you still have microfracturing. And as you know, microfracturing is widely used, but it's limited to the defect size. It has a limited tissue quality, and you definitely don't have a collagen 2 regenerative tissue. And for this, we started with Amic, and you can see an Amic where you could use a membrane or a gel to cover up the defect in addition to improve those effects. And obviously, the gold standard still is a 2-step procedure. It's the autologous chondrocyte transplantation, which finally is a 2-step and expensive procedure, and sometimes limited to access due to regulative problems in the different countries. Okay, so a lot of the basics are already discussed, and so I skip this and we'll step forward to the procedure itself, which has been described by my colleague Dr. Schneider and Gian Salzman and myself for an arthroscopic technique. And you identify to begin with the lesion, and you have this 4th-degree lesion. You have to make sure, and therefore we use a curette to have a very sharp and sharp-edged cartilage shoulder. You don't compromise whenever you can with a smooth cartilage, so you are able to really clean it up. And you use already these chips to harvest those and make sure that you have a good debridement of the synovia, so you have a smooth working space, and you're not especially if you work then later on with a dried out knee, that the synovial tissue will get in contact with the transplanted chips. So then after the debridement, and you have created a nice cartilage shoulder, you dry off the joint, you use this probe for this, or you can use even suction. And this is how we have harvested now with the graft net, the cartilage chips. We give a little drop of PRP to it, to ACP, a few drops to have a smooth tissue quality there. And then we give the rest of this altogether 6 milliliters of ACP into the trombinator to start the coagulation cascade. And then we leave it with this for a couple of minutes. And now we fill up the trocar with the minced cartilage chips. And make sure you stuff it in it, and you stuff up to the top. And now you already apply those chips into the defect, and you can see they stick to the subchondral bone. It's really nice how you can do it, and you can use the probe or the applicator, turn it around and use the other side of it, or you can use a probe to do this, however you want to do. And once more, that was already emphasized on don't overstuff. And by not overstuffing, we really can manage even big and large defects. And most treated defects by now, we not need to harvest it anywhere else, cartilage, than on the rim of the defect. So once more, we identify the defect, then we harvest the chips, we apply PRP ACP, and then we check obviously on comorbidities in those patients, instability of meniscus tears. We don't accept meniscus tears larger than 50%, because you need protection for the new cartilage. It's very important. It's obviously an arthroscopic setting in a supine position with a leg holder. And tourniquet should be high, 280 millimeter Hg, because you want to prevent bleeding while the procedure takes part. The graft net is applied to the shaver system. 3.5 is identified to supply the best chip size, and you collect it finally. If you look at this, alpha granulars are components of the platelets, and these granulars, they provide a high number of growth factors, components of the coagulation cascade. And if you see this chart, it's a little bit challenging, but catabolic cytokines, which have a negative effect on the cartilage metabolism, are inhibited by PRP, and factors which maintain the extracellular matrix are supported, and therefore we use these effects. You can see finally when we use the thrombinator fibrin clot here, you can seal off the defect, and it's just a few drops of it which seal off the defect here in a retropatellar case. And we have seen that allogenous fibrin versus autogene fibrin has a better outcome in autogene fibrin because it has a better matrix for the cells, which is supplied. And we use this 4 millimeter or 3.5 millimeter bone cutter to harvest the cells. And you see the visualization of the vital cells you are then supplying, and the chip size getting with those shavers. Collecting the cartilage tissue, weight-bearing versus non-weight-bearing, this is a different collagen composition. So if you take the collagen, you take the cartilage chips from not the ground of the defect or the edge of the defect, or you take it from the edge of the trochlea, that might lead to a different differentiation of those cells. So we suggest to take it from the rim or the defect side to get prepared. Because there's a high potential of redifferentiation, and this is necessary for the protection, finally, of the collagen 2. So uses, high concentration of vital and metabolic active chondrocytes is predominant in those ICRS3 grade 3 defects as proven. So here you see 40-year-old patient, retropatellar defect, and you know how hard those are to treat either with microfracturing or with autologous chondrocyte transplantation. In most procedures, you have to do an open procedure, but here you don't. So the cartilage defect is here on the patella. You do a debridement with your shaver system. Make sure that you get a sharp rim, and then once more the preparation. You have the cells, you collect the cells, and you do the ACP enhancement. We have that already. So subchondral plate must be clean but not hurt. So no bleeding from that subchondral bone is necessary. You have a stable cartilage border. That's what you want to have. You dry it off with a swab, and then you can use a mini open procedure in a retropatellar case if you want this. But you don't need it because you can apply now the cells. And we don't mind if you have some fatty containments there with the cartilage cells, because as you know, in the Hoffer fat pad, you might have a lot of proliferative active cells. And so it's not a pity to have those fat cells within this. So you model in the defect and you seal it off finally with the thrombine from the thrombinator, and then you're finished. How does it look like then? And here you see a trochlear case, and even moving the joint shortly after application of those cells, chips, into the trochlea can prove that they stick into the defect. You never do that proud, so you're not having a hypertrophy problem in those defect sealing. And you see it on the right side on the medial condyle here. You see it on the medial condyle here, and you can see you can move the joint without losing those chips. The fragment size influences the production of extracellular matrix. We know this, so just cutting those chips should be prevented. So we need those small chips to get successful. What we do is a 48 hours immobilization and brace. We have then a different procedure for femur and tibia as for trochlea and patella. For the femur, it will be 4 to 6 weeks non-weight bearing or partial weight bearing, depending on the defect size. We have a free range of motion starting 48 hours after the surgery. We use CPM. In trochlea, we only do 2 weeks of partial weight bearing. It's the half body weight, and then we start with full weight bearing. It's a limited range of motion in 30, 60, and 90 degrees for 2 weeks, and we use CPM. Cycling and swimming we allow after 6 weeks. And then we perform, as we see later, a 4-month MRI and a 12-month MRI to make sure that we have a good defect regeneration. So is unloading really necessary? And if you look here on an Autocot treatment in a horse with a direct mobilization, you see here the defect filling is almost overstuffed a little bit, but if you see then the rescope after 16 weeks, so maybe we should think about our post-op protocol in sense of weight bearing. What are now clinical and radiological results I can share with you? I show you different situations. Here a cartilage damage of the patella, 33-year-old active squash pro. He had a direct impact falling on his knee. You can see here the chip off of the cartilage, and it has no connection anymore to the subchondral layers. You see the bone edema, which is typical for the bone bruise in this situation. We filled it up again, and you can see you can really nicely work at the retropatellar surface, and it sticks to it, and we mold it into it, and we make sure that it's not over the top. Make it underlying the surface so you don't get the risk that you have a hypertrophy later on. And this is the result 6 months later. There's no bone edema anymore, and you see the defect healing has been completed. There's almost or hardly no effusion anymore, and you can see the defect healing as well here. So this is a complete healing after 6 months, and here the damage after 13 months or 12 months, you see no difference. There is no effusion anymore to the joint, no bone edema, and this is after 24 months in this squash pro player. So you can see it here and here, where we are very satisfied. This is a 27-year-old sports teacher. You can see here on the lateral condyle, the defect size is 1 centimeter in width, and in length it will be 1.5 centimeters. You identify no comorbidities anymore in this patient. And then the lateral femoral condyle here 12 months later, we have a nice defect filling, no bone edema, and the defect is completely covered, as you can see here as we enlarge this. Medial condyle, always the question, what is about age? This is a 62-year-old patient, quite active, and you see the defect size is 1.5 by 2 centimeters. We do the debridement, have a nice cartilage edge, and then we apply again the chips and seal it off. I speed it up here a little bit, and you can see it again that we filling up the defect quite nice, and then finally sealing it off with the fibrin clot to the end of the surgery. Again, in the 62-year-old, does it work? Yes, it works. You see the defect size here. It was 2 centimeters by 1.5 or 1.2 centimeters. So you can see the defect is nicely accomplished to fill it up. Femoral large cartilage full thickness defect. He is a radiologist, 55-year-old. He's an elite cross and field runner still. He's a world champion in orientating running. And you can see I did surgeries on his meniscus almost over 10 years ago. I did a meniscus repair this time again, but you see this is almost like a salvage procedure because the cartilage rim on the medial side is not quite good. You have it to the lateral side, it's okay. Obviously, this ACL is intact. So clean it off again, and then use the cartilage we have found here to put it into this defect. and then finally seal it off with the fibrin cloth. And as you can imagine, as a radiologist, he was giving me a lot of nice MRI images throughout his rehabilitation. And you can see here that we have a very nice and even cartilage repair in this, I would consider as a salvage procedure in this patient. And you can see this was preoperatively, this was 2 months later, and it's a growing process. And this is very interesting. You can prove it that even after 5 months and even after 8 months, you can see that the repair tissue is still improving. And 18 months after the cartilage transplantation, he gave me this WhatsApp, and now German champion in orientating running. The knee really did well, although the track was steep, wet, and rough through the woods. So this is quite a success. And he did probably 30 MRIs following the surgery. The medial femoral damage, 25-year-old patient. You can see the cartilage flap here, but if you see it on intraoperatively, this is not a situation where you can do a refixation. So we used this flap, debrided it, filled it up, and you can see here this was one of our early cases, and we had so much cartilage due to the fact that we had this flap. So we did a lot. We did a lot of, or almost an overstuffing in this situation. And you can see what happened here. After 7 months, we had this hypertrophy. And whenever something is wrong or something is not, congruent, you will see that the bone edema, even after 7 months, which will be normally now gone, is still evident. And this is the situation. So we got into, and we saw this really nice repair tissue, a little bit proud here to begin with, so and a little soft, and it was a hypertrophy. We do see with other procedure as well. So please be sure that you don't need as much cells, which we did here. So we did a coblation, and then after taking off the soft tissue, it had this hyper dense density. So the cartilage regenerated, what we then finally proved here to see as a result after 7 months. We did a histology in this patient, and you can see the cartilage chips, the vital cartilage chips right here with the vital cartilage cells. And you see the matrix, which is then connecting these chips to each other. And the histologist was really impressed by the vitality of the transplant what we were giving him. We have this one after 2 years. After 2 years, always when we have this situation, we have this little bit of hypertrophy. But this patient had this in the back of the transplant, and this is what we do. So what did we do? We followed up those patients precisely, and we did follow up 156 patients, 93 male and 63 female. You see the age is about 40. The body mass index indicates that these patients are normal weighted patients because they are high active patients. You see the defect location in percentage is about, if you take the medial femoral condyle, 38.5, the lateral femoral condyle is 18.9, and then the patella 19.5 and 12% at the trochlea. Only the lateral tibial plateau was only 2.4%. In sizing, we are focusing here mid-sized defects from 2 to 3 centimeters or 1 to 2 centimeters in more than 60% of the cases. But you see over 3 centimeters, we still have all put in this survey 27%. What happened to the patients? To begin with, they had a pain about 3.8, and then after 2 years, they were down to 1.5. And the subscale, we started with the cause and injury and osteoarthritis outcome score below 60, and we ended up almost at 80 after 2 years. In the Tegner activity level, they leveled out a little bit later. So if you look on the 1-year data, you see that they are not reaching to the level which they had before, about 4, and there we were about 3. But after 2 years, So when they lost or when they regained the confidence to their knee, they are back to the level of activity after 2 years. SANE, single assessment numeric evaluation, you see an increase at the year 2 up to almost 80. So we're very satisfied with the functional data. And if you look on all the other procedures we have experience with, and there are Amic procedure like Galen, where it's a study-based implantation, the PST guardrail, it's an Amic procedure, then minced Macy, or microfracturing, and you can see that the minced group is doing really well in the group of our cartilage repair, different cartilage repair procedures, as you can see here, in the pain, in the Tegna, where we're getting almost after 1 year there, where we were after before the surgery, and we are in the lead to the other techniques, and that's the same for the course. You can see that still are earlier results, but it's at least compatible with the other results. And we then used the Autocot 2.0 to evaluate the postoperative MRI, which has 7 items and looks at all the structures you can catch at an MRI. And interestingly, the Autocot patient did better. The literature data on ACI was evaluated too. We were ending up almost at 70. So in our hands, we have really changed our procedures. And you can see that 2/3 of our cartilage repairs are nowadays Autocot procedure, because it's single step, and available procedure. In conclusion, patient treated with the single step autologous cartilage repair, the Autocot procedure, show a significant improvement in VIS, COS, Tegna, and ACL RSE scores after 24 months. In the MOCAT, we followed up 12 months the patient, and we reached here a level of reconstruction of 7.7 of 100, which is a very good result. And the clinical and radiographic outcome is better or as good in comparison to literature and own data of Macy and Amic procedure. Obviously, we need further long-time follow-up to prove the long-time effectiveness of this procedure. So thank you very much, and open to a discussion.